medicine, and his research interests are neonatal clinical research and neonatal transport medicine and education. I had the pleasure of meeting Sam at the AMIA Clinical Informatics Conference early this year, and his passion for his work was immediately clear. I'm really grateful that he's here today to present to us from a different time zone to share his expertise and work with us. So Sam's talk is titled, titled Developing a Dashboard to Improve Antibiotic Utilization in the Neonatal Intensive Care Unit. So I'll hand it over to Sam now. Thank you very much.
Awesome. Thanks, Ron. I really appreciate it. And I just want to double check. We're good. You can hear me and see my screen okay? Perfect. Again, thank you, Ron, for this opportunity in NCAS to present on really how we go about creating data, clinical data, and how we used that to develop a dashboard to improve antibiotic utilization in the intensive care unit here at the University of Iowa. So, great. So the first question is, where's the University of Iowa? Well, the state of Iowa is in the middle of the US, and what's really important for context is our NICU sees about 1,000 patients a year. We here at the University of Iowa are world-renowned for our positive outcomes in extremely preterm neonates and our pioneering work in neonatal hemodynamics. What's also really important to know is that we are the only quaternary referral center in Iowa. So we are the reference point for a lot of the most critically ill patients here in the NICU in Iowa. For basis, today we're going to talk about early onset sepsis in the NICU, and so it's really important to kind of have a background. I know that a lot of you are not neonatologists, and so it's helpful to kind of have some background on early onset sepsis in neonates. What's really important to know is that about 80% of admissions to the NICU, these patients receive antibiotics. We also know that early antibiotic exposure in life is associated with increased morbidity and mortality in neonates. And from the review of the literature, we know that antibiotic stewardship literature is really focused on the outcomes of reducing antibiotics safely. But within this pioneering work to safely reduce antibiotics, it's difficult to find examples of actual processes that were used to analyze patient-level data safely. And so the question is, how do we start framing this problem so that we can create the data elements to increase our work efficiency? And so our first question that we asked here at the University of Iowa was, what does our antibiotic use look like for EOS evaluation treatment in the NICU? Surprisingly, we only had population data, like total antibiotic days for the entire unit, which our unit is 89 beds. And we hold, FYI, 10% of the patient population on any given day in our entire hospital system. But that didn't help us narrow it down to individual patients. We had, again, other data that said, hey, we have this many blood cultures and we drew this many cultures in total. But again, it didn't tell us exactly what we needed, didn't provide the nuance on that individual patient level to answer this question. So looking at the data and trying to figure out how we were going to address this, we noticed that, again, lots of articles on the benefits of judicious use of antibiotics for suspected EOS. And a lot of the articles said, hey, here's use an informatics specialist. But in all these articles that showed great outcomes and so forth in data, they never really talk about how they actually did it. And our busy work life has taught us anything is that manual labor, if it can be outsourced, it should be and automated if this is something that needs to be done routinely. And so today, really, the focus is on how we create the data elements and present them to help study and make decisions regarding antibiotic stewardships in the NICU. And so one of our first steps was, hey, we needed to build a group of content and culture experts at our institution. And when I say culture experts, I mean people who really knew the nuances and the ins and outs of the workflow. And so our multidisciplinary group included experts in health information who knew our IT system very well, neonatology, who are clinical experts. We had pharmacy experts and our pediatric infectious disease experts. And we all sat down and said, hey, we recognize that our institutions, as they become more complex, silos of knowledge are created, and there's always someone who knows something that you don't know or a better way to do it. And if you can't identify that person, often you are that person. And so we sat down and first things that we really wanted to do was, hey, let's look at our guideline. And our guideline here to the right was for our general EOS, evaluation and treatment for neonates admitted to the NICU. And in general, it's pretty similar to all the other ones that you'll see. And it really focuses on who gets started with antibiotics. But our group really did not want to address the clinical subjectiveness of that. And we said, hey, we really want to focus on duration, which if you look at our guidelines, don't really address that total length of treatment for sepsis, what constitutes an actual positive sepsis course, and how do we decide when to stop our evaluation? It says antibiotics for at least 24 to 36 hours there in the upper right. And so as a whole, we said, hey, how do we figure out antibiotic duration and how can we make appropriate decisions to help guide our interventions? Secondly, we wanted to be thoughtful of the process because we knew that we were likely to expand what we're doing here to other projects, i.e. late onset sepsis in the NICU. What does antibiotic usage look like in our very premature infants, and is this positive or negative? And so we had to focus on this, and so the first steps then is how do we narrow this question down? And it's working with a data analyst, right? And if you're like me, my first experiences working with a data analyst were, hey, let's create a report on patients admitted to the NICU who are treated for EOS and look at their duration of treatment. That sounds really easy, and I would always get responses of crickets, right? I'm not a programmer by trade. I'm a physician first. I know clinical workflows, and my background in clinical informatics and in databases and mathematics have been really useful, but I'm a terrible programmer and I didn't know the background there. And that's where my data analyst is. And so we really have to be thoughtful about how we work with our data analysts because their expertise is not in clinical medicine and we have to frame it for them. And so how did we gather this data and frame it with our data analyst and team? We said, well, let us look in the last 2 years of all our patients and decide what that data looked like. 2 years we figured would give us about 400 odd patients, and that would give us an appropriate trend. So said, well, what is the population that we wanted to narrow it down to specifically? And so here are the inclusion cohort criteria. Just like in any neonatal study or scientific medical clinical study, you have to have a cohort. So we had certain criteria, right? You had to be admitted to the NICU. You had to be at least 35 weeks or older because, again, gestational age mattered. Smaller babies, younger babies were a different population, and they had different reasons for coming out. Thirdly, we said we really wanted inborn status. And this is a nuanced part because outborn babies could have gotten antibiotics, and we knew that information wasn't going to be in our electronic medical record. And so I couldn't tell you when their first antibiotic doses started. And so we really just wanted to focus on the kids that we were fully responsible from start to finish. And then 2 antibiotics started within the first 72 hours of life. By definition, that was our EOS definition. So looking at what admission to the NICU looked like, talking to our analyst is like, how do we isolate babies to the NICU? You know, my analyst goes, hey, first off, what is the definition of a neonate? Are they different than babies? Are they different from children? Secondly, what is the NICU? Is the NICU a special unit? Is it a special place? Is it a totally different building location? Is it like the ORs? Again, we have to clarify and be intentional about all these elements, because data analysts, not necessarily clinicians. It'd be like asking me, hey, Sam, help us in the adult ICU. And I'd be like, I don't know the last thing to do for an adult patient. I couldn't tell you where the data things are. I couldn't tell you what the workflow would be. And so we have to just frame the question and be very thorough in this. And so this leads me to my first kind of pro tip of gathering data for projects and working with our health information systems and data analysts is be very intentional about investing time up front to define the context and objective of your data query with the analyst directly. Rarely does an email work or convey fully your question or details. And two, if that is the only way you work, the responses are often incomplete and the data will not be quite right ever. My personal experience has taught me virtual or in-person discussions with examples have made things infinitely faster. So when you see and are actively involved in the data creation, and again, two, it's much easier to address things when things go wrong because you know the process that they made and how they did it. And this ultimately leads to the final part is accurate data into your system means meaningful data out, right? You can't generate good ideas and good decisions if the data is faulty. And so ensuring these initial steps helps us get to that final step of making good decisions based off of good data. So the question then is, how do we do neonatal admissions here in our data system? Well, we have a NICU admission order, and you can see it there on the right. These admission orders have a specific ID identifier. This means I can tell which patients actually had this order. Two, this order contains an admission date, which is helpful for limiting our searches. Three, the admission order then says, hey, if you find a patient with an admission order, it is now linked to their medical record and patient encounter. So you get a name and an MRN. This also then helps you with date of birth and other information that we would need for clinical data elements, like day of life at admission. Lots of data is embedded within this admission order, and this is where your data analyst's expertise is. I don't have the subscreens to show you within the server level of what that data looks like, but again, every order we place is linked to some framework in the background, and we'll see it here. Now we know how to identify kids admitted into the NICU, but how do we filter it by gestational age? Here down below is a screenshot of a patient with a flow sheet of their data. At the bottom, you can see NICU gestational age of birth, 37.37. This is a data object that is permanently stored. You can see the day of life at this time point, and what is excellent and nice about the EMR system that we use is that I can tell you what row and the group ID is for that data. I can point to it, click it, and it says, hey, this row ID is 25477, and I can go and ask my data analyst, this is what I want. Can you search this row for X data point? And this is, again, super helpful because, again, you now know where the data is stored. I showed it to my data analyst. Data analyst is like, great, here's a perfect example. I'm going to go grab that for you, and we can use it. So now we know admission to the NICU filtered by gestational age, but how do we do inborn and outborn status? This is tricky for us here. We don't have a specific queryable location that says this patient was inborn or this patient was outborn. It is actually free text in the node. And it's not something that I can query by that row ID or group heading. And I don't have the power to do large language models to read HPIs and say, hey, yes, this clearly was an inborn patient. I know that when I read the note, but the computer doesn't, and I don't have an algorithm to give it to that. So how do we get around this problem if we don't have a directly queryable information spot or object ID for this very important clinical data? We say, well, let's find a substitute marker that isolates inborn from outborn patients. And what we know here is inborn patients have a delivery summary report that is completed, right? It tells us who was at the delivery, what time it occurred, what the complications were. And so for all babies born at the university, we have this delivery summary report, and so we can ID that. The challenge is, do outborn patients have that? Typically not, unless someone goes back and fills one in. And so it is inconsistent. Secondly, what do we know about outborn patients? They have a transport record, right? The team had to go pick them up, and that gets imported into the record, and that becomes a searchable item. You have to be able to expand it out. And so we have general rules that say, hey, if you were an outborn patient, look for this transport record and or a lack of a delivery summary. If you have both a transport record and no delivery summary, the chances are almost 100% you were an outborn patient. If you have an inborn delivery summary report and no transport record, sorry, delivery summary report, but no transport record, you are almost guaranteed to be an inborn patient. But that's not always the case. Data is nuanced, and this is where clinical expertise comes in. And so we recognize that there's some challenges with this. We're using substitute markers. What if the patient was brought in by another team? I don't get a transport record then for that in my system. Sometimes we input delivery information into a delivery summary report for outpatients, which confuses it. And so there's always the chance for missing, and it's important to recognize the limitations of your search. But because I made it with my analyst, I was able to recognize these things. And so narrowing down patient cohorts, we start off again in summary, all the patient encounters in the data system. We break it down and limit it, then filter it through NICU admission orders and a date frame. And we keep narrowing it down now with the gestational age limit and continue adding on another data element of being an inborn. Now that we've finalized our cohort, we can generate a data table report. Often it just looks like an Excel sheet data table, and SQL or most databases will produce this for you in some manner or form that you can export. And here we see kind of a generalized idea of what one of those look like, but you can see there are some goofiness, right? Like they're missing data. Like I don't know what the gestational age at birth was, or the PMA in that example at the bottom, or an outborn patient. And again, this is where regular reviews of the data, knowing how the data was made with your data analyst, you can address some of these oddities. No report's ever going to be perfect. And so revisiting and readdressing and reviewing is always of this. And so the last step here is we had our patient cohort. We got to define EOS. So we said 72 hours of antibiotic use. So the first part is we have to know all the antibiotics that we use in the NICU, and we have to be able to identify them. Fortunately, all orders for antibiotics have an order ID, and we can then isolate each antibiotics. Two, once they're ordered, they also have administration dates and times, and we can grab that data subfield, and that's what we would narrow it down to. But the important part here is we recognize that some things are missing. Antivirals and penicillin were missing. And again, this is where your clinical expertise helps supplement the data expertise of the analyst. And so all this then becomes, hey, I've added now antibiotics. I got dates and times for administrations. We can combine that now with administration times and figure out, did this patient receive antibiotics in the first 72 hours of life, right? Here's this antibiotic order that has a date and administration time, and we know the date of birth time. Subtract it, and if it's less than 72 hours, bang, they are in the EOS encounter. And so here is just a quick slide of summarizing some of the key data elements that we just quickly ran through. And now combining it all together, we make this report that looks kind of like this. This is a single patient who's had who's had 5 antibiotic doses. We check first antibiotic dose, first 72 hours of life. Yep, date of birth on the far left, 219. Medication was given on 220, so somewhere within 24 to 48 hours of life. Duration between doses. We can then calculate the time in between doses manually by just subtracting those times. And we say, oh, this was less than 24 hours. We use the 24 hours because we need to find a good endpoint to stop the episode, right? We need to start in an endpoint. And this was kind of an arbitrary thing, but we said, hey, if no antibiotics are given 24 hours, it's likely that it was an intentional stop point. And so this is how we calculate the total duration of antibiotics. We looked, and if there was no antibiotics given for more than 24 hours, that was the last dose. And then we calculated the first and last dose time difference to get the total duration of antibiotic coverage for EOS. The importance part here is that we show our data analysts what we're looking for. And then we say, like my old math teachers would say, the exercise is left to the learner, right? I let my data analysts go figure out the best way to translate that manual process into code. And the beauty of it is data analysts tend to be very good at that. And you and I don't need to sit around for that. We let them do that in the background. All that data then can be then transposed and summarized. Here we have a histogram of that summary data of total duration of antibiotics for EOS between 2021 and 2022. My medical student at the time, I'd spent a couple nights breaking it down for 451 patients manually, and this is the table that we got. You can see data life 3, 4, and 5, or sorry, not data life 3, 4, 5, durations on the bottom of 3, 4, and 5 days are kind of odd, right? Our goal was 48 hours, or we wanted 6, 7 days of antibiotic treatment for early onset sepsis, but we got 3, 4, and 5 day numbers, and they're pretty regular. And so this gave us a target. We said, hey, likely we could reduce antibiotic usage if we eliminated or reduced these 3-day, 4-day, 5-day antibiotic courses and ask people to kind of shift it either to a 48-hour or to a 7-day antibiotic course. This group here, composed almost 19% of all patients admitted for EOS in those 2 years, and again, could result in significant reductions of antibiotic use. So I showed you the manual way of how we did it, but you can create an automated way, and this is the SQL or the program coding to do it. They use a function called islanding, an island function here. You can see it in the top row, and it really says, hey, if there's a gap between any antibiotic dose of more than 24 hours, this episode or period of antibiotic duration should end at there. And then we take that first episode and we calculate the total duration to get us that total duration of early onset sepsis treatment. And so at the end of this is we have an automated data report that does it for us. And we have examples, we know what we can do with it. And we export this now, this whole data set to a server, and we can set targets with it. We said to ourselves, we have this data. Let us do something. Let us create an order set that limits antibiotic use to 48 hours and force the team to make a decision. Either you stop or you continue, right? And you can see in this image down below, we limit it to 6 doses for ampicillin at a Q8 schedule, 48 hours. Q24 dosing for 2 doses with gentamicin, again, 48 hours. You can always stop it sooner, but if you want to continue it more than 48 hours, you got to be intentional about it. And my colleagues and I all agreed on this, and we implemented it. The best part here is that this order set is trackable too. Just like every data element we create, there's some ID that we can pull to see that the antibiotics were being used from this order set or not. And so all this data gets then outputted into the SQL server. That data table then says, we can reference it with our graphics part. This is where the dashboards start coming in, right? It's clinical outcome tables are then created based off of how you want to do it. Just like in Excel, you can make histograms, you can make line plots. It's all yours. The data is sitting there, the variables are sitting there. You can see on the right here, we could filter the data like what patient population age group do you want to look at? Just 35 weekers, 36 weekers? You want to look at kids who had positive blood cultures? You can add variables like that. And here we can see a reduction pre and post antibiotic order set of about 5% in these two epochs. And it was a helpful diagram. And again, dashboard is pretty simple, but this wasn't a perfect representation because you had to manually calculate it, and you're like 5%. It's hard to see that reduction in antibiotic use. So instead, like any good quality improvement project, we made a run chart. Here you can see our pre-EOS order set and the percentage by month of patients who were getting more than 48 hours of antibiotics who were being treated for EOS and post-EOS. The pre-order set mean per month was about 49% of the patients who met our cohort criteria were getting more than 48 hours of antibiotics. And then post implementation, we were down to about 36%. Above, you can see our order set usage. And what's really kind of interesting is that the order set usage doesn't really correlate very well with our use of antibiotics greater than or less than 48 hours. But overall, there is a trend to improve usage of the order set and reduction of antibiotics given for 48 hours. And so this is my encouragement. This is the beauty. Now that you kind of know how to build data elements, you can use these queries and logic to create more elements, and it can be easily adapted to address other projects, right? You can expand your queries to look at other patient groups, right? As we said, what about late onset sepsis? You know, babies being treated in the NICU for after the first 3 days of life. What does that look like? We can look at other neonatal populations like the extremely premature babies. We can look at surgical patients even. We can expand the variables that we look at, right? We can add microbiology results like blood cultures or CRP results, and we can gain greater insight that way into our data sets. Two, you can expand the application of your data to other projects, right? Like you can use them for other quality reporting metrics and groups. You can use them for research collaborations. You can use them for like insurance reasons. But because you know how they were created and you were actively involved, you have much more power and authority on this. And so some additional take-home points are how to work in creating a data request to a data analyst. You know, spend time upfront reviewing what data is needed, what your project goals, and how you anticipate using it. Give them a framework to build and target. Know your clinical workflow and how you identify that data. Provide clinical examples of data that may be more nuanced, like inborn, outborn status. And again, show them how you would go about calculating it manually. Again, then you can always do this. Other points are leverage the expertise from multiple disciplines, particularly those experienced in both the clinical practice and informatics, right? I'm fortunate that I have done a little of both, and I can act as a translator sometimes. And then the last part is, even though the computers are super powerful and super fast, it still takes time to revise and perfect. The first draft is never perfect. And it's that discovery of knowing what is being missed, and that comes from your expertise. And so keep revising, keep reviewing, and it just takes time. Like any good QI project, you got PDSA cycles, and you just keep going back through. You say, hey, what can we add? What can we refine? This doesn't look right on the surface level. Does it not? Let's drill down and affirm that this data is accurate and what it's representing is actually what we're looking at. And so here's a brief bibliography of some of the resources. And again, none of this work is doable without the team that collaborated with me: Lucas Weiner, Pat Kinn, Michael DeBlah, and Casey Jacobs. And I'm going to stop sharing and open it up for questions.
Great. Thank you, Sam. That was really a nice presentation. Yeah, opening questions to the floor. You can post it in the chat. just while we're waiting for that, I really like what you said about rarely does an email work, and you need to define the context and objective for the data query. I think it drives the message home with a lot of these kind of projects. Perhaps one question I had was, how do what's the next steps here? I think you sort of touched on it. So once you've built a dashboard, what are some of the strategies to ensure continuous updates and relevance over time, particularly if clinical practice changes?
Yeah, and so you look for drift, right? Like drift or sudden changes in your run chart. That's why we have that run chart data. I insisted early on that we create a run chart for that reason, because that's the easiest way to monitor it. Those histograms are actually really subtly, they look very similar, right? And I am not one to want to sit and redo calculations manually ever if I don't have to. And so this run chart is super helpful. And if I see suddenly a spike, we go back and say, hey, what was going on? Is it because we actually had kids who were being treated for a full duration of EOS, more than 48 hours? Or was this a gap where we didn't use the order set? And we can track it down. We can see who ordered the antibiotics, and we can give friendly reminders or again discuss. All right. It's all about communication, but the more data you have, the more data you are able to tailor and be focused in how you want to address it, right? Like if you don't know, you can't do anything about it. And this is where that comes. It's friendly reminders and so forth in that regards. And so QI is a great spot for it. Things that are repeated over and over, right? Like I don't have time to sit and review 40 charts and manually go through them and be like, how long was this calculation, during antibiotic duration? I don't think anyone enjoys that either. And that's a great usage of your computer, right? Delegate it off to a machine that does it in the middle of the night, but the time is reviewing it, making sure it's accurate. And that's where the upfront costs come in. And it is a process. And so we just keep growing it. So the next stage is late onset sepsis in the NICU. Babies being treated after the first 3 days of life. How many episodes are there? How many kids are being treated and for how long? Again, it comes down to antibiotic days overall, but also, directions in that regards. And so we use those in metrics and we can refine our guidelines based off of that data.
Thank you, Sam. There's just one question, quick question online, sorry, before we move on to Vlada. So thank you for the great talk. How did you define antibiotics in your query? Was it using some sort of codes, and were you able to exclude antibiotics not for sepsis?
Right. In the NICU, right, like all antibiotics in the EMR are identified, like specific, like ampicillin IV is a different ID and order identifier than oral amoxicillin or ampicillin. Gentamicin IV is a very specific order ID. And so we said, hey, we know we use these antibiotics almost exclusively, right? AMP and Gent are the foundation of neonatal antibiotics, at least right at the beginning. There are outliers to that, right? Sometimes we use AMP and Ceftaz for certain kids. Sometimes we'd go straight to Pen-G or whatnot, right? Antivirals, acyclovir or Valgan or whatnot. These are the unique ones, but we say we have standard order sets that we use in the NICU, and we don't particularly vary from those order sets terribly much. And so again, within those order sets, each antibiotic has an identifier, and we just throw it in the computer system. Again, it's super cheap to do. 1 or 2 lines of code, done. Imagine trying to, again, scroll through every medical record looking for every antibiotic. You don't want to look at that. And so we just say, here, what antibiotics do we use? Penicillin, ampicillin, gentamicin, vancomycin, Zosyn, acyclovir, Ceftaz, cefepime, et cetera, et cetera. And again, neonatology is lucky in that we don't use a plethora of antibiotics, at least not at my institution. I think that's generally an easier thing to do, but every database has an antibiotic list, and you can just copy it and say, look at for this order. Did it exist in this count? No, done. If it does, give it to me, and it just spits it out seconds, milliseconds per patient. It's super fast.
So
Thanks.
Think we might have to move on to the next speaker, but thank you again, Sam, for your really good presentation. I'm sure you'll be happy to take further questions. So all our presentations are available online after this seminar. So I'm sure you're happy for us to share your email if you have
Yeah,
any
not a
further
problem.
questions. No worries.
Absolutely.
Right. Okay. We'll move on to our next speaker. Thanks, Sam. Our next speaker is Dr. Vlada Rozova. She's a data scientist and machine learning practitioner passionate about developing automated systems to improve patient care. She has a background in applied mathematics and computer science and is currently a postdoctoral research fellow with the Center for Digital Transformation of Health at the University of Melbourne. Vlada, quote, enjoys the interdisciplinary challenge and loves seeing the development and implementation of tools from start to end quote, which is fortunate given her very important role as the postdoctoral machine learning fellow and chair of the NCAS Data Science Initiative technical committees. Vlada will be providing an update on the NCAS Data Science Initiative. Over to you, Vlada. And thank you for joining
Ron.
us today.
Thank you. That was a lovely intro. So I was asked to give an update on the NCAS Data Science Initiative, but also give a little bit of a background, being conscious that this is a mixed audience. So I'll talk a little bit about just, AI in healthcare and what can we do with that and some of the, I think, important considerations. And then I'll give a bit of a sneak peek of the project that we've been working on with Ron and with a lot of people from the NCAS team. So a bit about data-driven solutions and the benefits for healthcare. And by data-driven solutions, I use this term a little bit loosely. You can say it's AI, you can say it's machine learning. It can also just be a set of rules that you have worked out through looking at the data and sort of establishing some patterns manually. Doesn't really play a big difference when it comes to implementation and validation of these solutions. So one of the benefits is that data-driven solutions allow us to deal with large, complex data sets. We move past the data collected in controlled settings, such as randomized controlled trials or cohort studies, into this wild west of electronic health records, insurance claims, omics data, anything you can think of. It allows us to work with different data modalities. So healthcare particularly is an industry that's quite still heavy on free text data. A lot of important information is hidden away, tucked away in progress notes or ward notes. And so it's really important that we can apply some natural language processing to get some important information out of the clinical notes. Diagnostic imaging, obviously, a huge domain as well, but also EEG, different time series data, different just simple tabular data like vital signs or different indices. We can combine all these modalities, we can fuse them and leverage them all together. And the third bit, I think that's really important, is knowledge transfer. So AI allows us to transfer knowledge quite efficiently between data-rich and data-poor contexts. What do I mean by that? I mean, for example, I work a lot with Royal Melbourne Hospital that collects a large amount of data, sees a lot of patients yearly, has electronic health records, and there is a huge potential to learn something from these data. Now, it's not guaranteed, but there is a chance we can learn something, some patterns that then can be taken out, say, to regional or even rural settings where there may not be as many patients, there may not be even electronic health records implemented. But if we can capture these patterns and if we can validate them in the different settings, then we can benefit from this knowledge transfer. We can also transfer knowledge across different clinical domains. And this is, I guess, something the NCAS Data Science Initiative is trying to do, is transferring knowledge across multiple different domains, being hospital, GP, and veterinary. I think there are many components of success that would, I guess, would need to be satisfied before we can really say that we can use AI in healthcare, but at least 3 of them, I think, are user-centered design, thoughtful implementation, and ensured transportability. And I'll just go through all 3 of them to unpack them a little bit so that we're on the same page. So user-centered design, what do I mean by that? I guess one thing I mean is that digital health solutions are really software solutions. So as any software solution, as any piece of software, it has its end users, whether these are, back-end software solutions, which are only seen, or the end users are only EMR analysts or the IT department in the hospital, or maybe it's a solution like guidance, which is the end users are prescribing clinicians that have very different needs, very different interests, very different set of skills, and so on. And I think what we often assume, at least in the field of machine learning, we tend to get often motivated by the methodology. We get excited by the new models. We want to apply them. We get our hands on some data, and so we want to test it and explore it. And I think what gets missed out sometimes is what is really needed by the end users. And so I think we really need to think about designing our tools to meet the user needs. And that, for me, means working closely with clinical stakeholders, with clinicians, with pharmacists, with veterinary sciences, and so on. User-centered design is not just about the user interface. It affects every step of the development. We, for example, can design the user interface, but really, by designing that, we define what is it we want to present to the end user. What do we want the functionality to be? And that defines how do we process the data? What sort of models do we build? What do our models predict or output? How do we process these outputs? How do we incorporate them into the end user workflow? The next component is implementation, and I feel like this is still, we're still in the early days of it. We're still very much as a community working out how to implement AI solutions or data-driven solutions in healthcare at scale. We work with highly sensitive data, patient data, so both development and production environments are usually highly constrained and under-resourced. And we work with data custodians, whether this is the hospital or a research data set, that have their own set of policies and regulations that impose additional restrictions. Because we work in highly constrained and secure environments, because there are concerns for security and privacy, there is often no cloud storage or computational resources available. Samuel mentioned that, he wouldn't necessarily run a large language model. And part of the reason why is that because we just cannot physically do it, because we don't have the resources to do that. There is usually no access to the internet. It might not speak to many of you, but a lot of the servers in hospitals are Windows operated. And for a computer scientist, that is sometimes a pain in the neck and brings some additional hurdles that need to be overcome. There is also rarely provisioning for maintenance by the funding bodies, at least from what I've experienced. There is a lot of focus on, the development stage or phase of the project, and maybe even implementation, but there is still little recognition that any software that's been implemented needs to be maintained, needs to be validated continuously. We need to monitor its performance. We need to, if the performance drops, update it. We need to re-implement it, redeploy it. And God forbid there is any structural changes in the IT of the hospital we're working with, because that would probably bring a whole lot of new tasks that need to be accomplished. And the third component is transportability. So we do not expect any clinical AI that we develop to be a one-fits-all solution. We don't expect it to generalize, across the world. We've seen the EPIC sepsis prediction tool showing very different results across different sites. But we would like to build solutions that can generalize at least maybe across the state. So, for example, we in Melbourne have multiple large urban healthcare providers. Wouldn't it be nice if the solution we built could be implemented at each of them? Maybe then we could think of going to regional Victoria, or maybe crossing the state borders. Ideally, we'd like to scale nationally, but that's a much bigger undertaking. And the reasons for that is that AI or data-driven solutions are really prone to various drifts and biases and errors when there are differences in patient populations, when there are differences in data management and information systems, when hospital protocols are different across facilities. We've seen all of these sort of not problems, but I guess factors manifest themselves, and it's quite dramatic to see the performance of a model that's sort of looked really promising starting to suddenly go downhill because the language being used to describe a certain condition is different, or because the patient population is different. So yeah, and I think the natural language especially brings a lot of difficulties, because the data we work with need to be similar. We can make sure that we use the same MRI machines or blood glucose tests, and these probably will give consistent results across states, countries, continents. Natural language is much trickier, and we make this huge assumption that we operate in the English-speaking domain. So the English language is the most resourced when we talk about natural language processing, and yet even there in processing of natural language of clinical notes, there is a huge variability, and so there is a lot of trickery that comes with making sure that NLP tools are consistent in their performance. And as I said, a lot of important information is hidden away in clinical notes. So perhaps what we really should think about is how to standardize it further, how to shift our focus from locking information in free text to kind of trying to standardize it and present it through some sort of tabular data in electronic health records. And so the project I wanted to give an overview of is called it's a research data infrastructure grant. And the purpose of that is to build some infrastructure that would allow us to sort of first it would allow us to make sure that our data ingestion and transformations are consistent. It would allow us to design some fit-for-purpose data models and standardize data from multiple sources, and then create research data sets that allow answering specific clinical questions. So what we have is electronic health data from hospitals, from GP clinics, and from veterinary clinics. And each of the streams combines multiple facilities. So with hospitals, so far it's just 2 hospitals, but GP clinics and veterinary clinics are both databases that themselves pull together multiple different EMRs, multiple different clinics together. And what with this project aims to address is, it aims to address AMR, which I'm sure everyone knows what antimicrobial resistance is and how important it is to tackle it. And the way we are trying to address it is by assessing antimicrobial prescriptions. So the power is in the knowledge and the awareness. And I guess the first step is to just even being aware when the prescriptions are incorrect, inappropriate, when they don't align with the guidelines, and then we can then further act upon that. So we're addressing the AMR. We're doing it through the One Health approach by sharing the knowledge between human and veterinary and animal spaces, and then by applying some clinical AI magic dust on top of it. And again, using the term AI or clinical AI very loosely here, that is not just machine learning, that is also incorporating, building data transformation pipelines that would be robust, that would allow us to transform our data consistently over time. So where does it sit and what does it look like? I think when we talk about analyzing real-world data, there is a spectrum of applications that we can look into. And on the left-hand side, it's clinical research. It's often retrospective and explorative. We export or extract the data once. We explore different algorithms and different methodologies and ask different questions. As we move along the spectrum to the right-hand side, we start sort of hitting more real-time decision support. So maybe it's lighter, more agile solutions, but they come with a whole lot of software engineering wrapped around them, because these are tools that are literally plugged into the electronic health records that provide real-time support or real-time feedback, if you will. So I feel like there is a bit of a spectrum between the two. The NCAS Data Science Initiative is sitting somewhere close to the middle, slightly on the left. We are looking to ingest data quarterly at the moment, and this is still very much aimed at building a research data set rather than providing an ongoing clinical decision-making support. But there is opportunity to, I guess, speed this up in the future and explore whether we can bring it closer to the right-hand side. So what do we have here? We have, as I said, our hospital data, we have GP, and we have veterinary. Each of them looks completely different. Like the electronic health records are completely different. There is no conversation about interoperability. So each of the streams require their own data processing. And this is quite extensive. That requires understanding what the data looks like, what fields are there. Even the simplest example, like patient sex. Is it sex? Is it gender? Which values are allowed? What are the values that encode particular social constructs? Is it 0 and 1? Does 0 always stand for male? Or are there additional values that are allowed? And how do we define those? So across hospital and GP, we can ensure that we're using some sort of standards. For example, Australian Institute for Health and Welfare recommends standards for such variables. Veterinary space obviously is different. So we need to sort of as we're trying to tie all these three streams together, we need to be conscious of the inherent differences in the data. So we built custom databases for all three streams, and these are, excuse me, in isolated environments. Even though the data undergoes quite a bit of transformation, it's still raw data, and the data custodians feel often that this is still sort of the data that belongs to them. And so they would strongly encourage, the data being stored and isolated in secure environments that they are comfortable with. And then from there, we try to create this common data model. So what that is, for example, we want to assess antimicrobial prescriptions across hospital, GP, and veterinary. What are the fields? What are the features? What is the information that we need to be able to assess an antimicrobial prescription? Obviously, it's the medication given, the indication for which the prescription was given, but it's also some sort of clinical characteristic and host factors like the smoking status, the pregnancy status, whether they have any kidney disease, and so on and so forth. So we define this shared data model that incorporates all the bits of information required to make an assessment of a prescription. And then what we try to do is we try to pull this information from each of the three streams. And that allows us to build this research-grade data set. So by that point, hopefully, this is a single data set or three different data sets, but the fields are the same in each of them. So we can go further and extract the standardized prescriptions and then develop a tool for automated assessment of these prescriptions. And then the tool will let us know whether, the prescription is assessed, was prescribed appropriately or not. And that's sitting in a secure environment with credentialed access for researchers. So this is the research infrastructure that we are building. And so I guess some key components that I've just mentioned is that there is very stream-specific data transformation, but as we go along this journey, we try to unify further and further the definitions, the more data models, the principles for data analysis, to sort of the infrastructure is consolidated to bring all these three streams together. I was also asked to sort of reflect on some learnings from this project that I think have been very sort of insightful for both the technical and the clinical team. And one of them is shared definitions. So we need to make sure that we speak the same language. And I think Sam also alluded to that. Something may be intuitive for clinicians, but it's really difficult to define in data-friendly terms. And to be honest, vice versa. So for example, how do we define UTI? Someone looks at an indication or at a clinical note, and they can straight away say, oh, that's a UTI. But for me or for the machine, that's not obvious. And so it's really important to have a clear definition of the particular condition that we're fishing for. Courses of treatment has been another sort of point of many discussions. How do we define a course of treatment given we have multiple prescriptions over time, for example, over a hospital admission, with potentially unknown or different indications? How do we still, there is a feeling, a gut feeling that it's still the same course of treatment, but how do we break it down in data terms, and how do we define an indication that changes over time? Data annotation, we want, as I said, a lot of data is hidden in, a lot of information is locked in free text. And so to extract it from there, often we need to annotate the data. So we need to give the interpretation. And we can start looking for these concepts once we have, established our definitions. but who is the data annotator? And from past experiences, we've learned that it's really important that the annotators are the decision makers. So not someone with relevant background, not medical student, not someone who's, familiar with the data, or maybe even creates the data, like radiologists generate radiology reports. It needs to be someone who acts upon it, who is the decision maker when it comes to interpreting the data in the traditional clinical workflow. And data governance. I am lucky to not have to solve all of it myself, and I contribute very little to that, but I just want to acknowledge how much work goes into this, into getting, the ethics and data governance approvals. Every data custodian has their own set of rules and policies, as I said, but they also have their own interests and obligations. And there is a lot of sort of negotiation that goes into making sure that everyone is happy and comfortable with the infrastructure that we're building and with the use of the data that we're going to make. Yeah, that's it. And I'm 1 minute past, sorry about that. And thank you very much for your attention. Happy to take any questions if there is time.
Thanks very much, Vlada. Does anyone have any questions online? I think we had one question on what type of data, it's when we talk about vets here, what type of data we have. I know the answer, but I'll let you answer that, Vlada.
Oh, yeah, sure. Yeah, so these are pets so far. These are dogs and cats. And I think there is potentially there will be horses at some point, but I shiver when I think about it, because I think I can imagine the clinical workflows are quite different. So it would be yet again sort of almost a different stream of information coming in.
Given that we're already over time, I might just end there and thank our presenters. So thank you, panelists, for staying online, helping me out, and the speakers. You've been both really awesome today. And thank you all, the audience, for attending. Now, just before you all go, Caroline just has a quick announcement to make. But I just also want to say a big shout out to Sam for joining all the way from the US. If you're ever in Melbourne, bowl of pho or maybe more 2 bowls of pho on us. All right, over to you, Caroline.
Thanks, everyone, and thank you again to all the presenters today. It was fantastic. So that was actually our last NCAS seminar series session for 2024, because next month is all about our World Antimicrobial Awareness Week event. And just to quickly give it a little plug, but this will be an in-person event in Melbourne only. The registration details are there on the screen. And we would love to see as many of you there as possible. So the today's session has been recorded and will be popped onto the NCAS website and our NCAS YouTube channel sometime later today. So thank you very much, everyone, and have a lovely day.
Thank you, Ron and Caroline.
Thank you. Bye.
Yeah.